Hey folks, welcome back. Today we're going to be talking about schizophrenia. More specifically, schizophrenia is one of several psychotic disorders, but for the scope of this class, we're going to focus primarily on schizophrenia. We're also going to be talking about medication more broadly as a treatment approach. But before we get into schizophrenia, let's talk for a minute about psychosis, because that is really kind of the category that we're focusing on. Generally speaking, we use the term psychosis to describe someone who is quote unquote out of touch with reality. And typically, this entails a combination of unusual thinking patterns, distorted perceptions, and odd behaviors. The two hallmark symptoms of psychosis are delusions and hallucinations. A delusion is going to be a false belief. So, believing in an a fact, an experience that is not based in reality. And a hallucination, as we discussed in the context of the substance use disorders, you guys know is a false sensory perception. So seeing, hearing, feeling, tasting, smelling something that is not in fact there. However, despite the fact that these are considered really the core, hallmark, tried and true symptoms of psychosis, just because we are observing a delusion or a hallucination doesn't necessarily always mean that we are dealing with psychosis automatically. There are actually several disorders that we've talked about to this point that entail those symptoms. Typically, if I were teaching live, I would ask you guys to give me examples, but since I'm pre-recording this, I'll list a couple out for you. So we've got, body dysmorphia and anorexia as two examples that can potentially become delusional. We talked about several disorders with respect to the degree to which those folks are in touch with reality. And with body dysmorphia and anorexia, we talked about how, the way these folks are observing themselves and experiencing their bodies when looking in the mirror is almost delusional, that they're looking in the mirror and they are not really seeing or perceiving their bodies as other people do, and they truly believe that they look differently than they do in reality. So those are two great examples of delusions cropping up. You'll also recall the example of mania that I gave you guys in our mood disorder chapter, John, that he had a diagnosis of a bipolar 1 disorder, but that he was a good example of someone with those psychotic features. He was actively hallucinating in that he was seeing and interacting with God in a way that is very atypical, even within religious contexts. And he was also deluded in terms of believing that the cure for cancer lied in these newspaper clippings that he had. So it's possible for several different disorders in their most severe forms to become psychotic, like mood disorders. And then, of course, as far as the substance use disorders go, there is a whole category of disorders called the hallucinogenics, really only one of which we discussed, cannabis, in that particular chapter, but there are other substances within that particular category. All of those can obviously induce hallucinations via intoxication, but hallucinations can also be induced by a withdrawal as well. Alcohol would be a good example of a substance that does have a hallucination as a potential withdrawal symptom. So these are just some examples of how these symptoms can crop up in other areas. But again, these are really kind of the core of psychosis, the hallmark symptoms that we're looking for in diagnosing these disorders. But again, just because you see a delusion or hallucination doesn't mean you can automatically assume it's a psychotic symptom. Psychotic experiences may also be associated with medical illnesses, things like Alzheimer's, or brief, limited psychotic experiences. Typically, these brief, limited, short, bridged, acute experiences are things that are brought on by acute stress. Grief is always the example I give. So sometimes when people are acutely grieving, they may be experiencing delusions or hallucinations relating to the deceased or angels or something like that. These experiences impact anywhere between 2 and 12% of adults, and typically they're associated with more positive beliefs or sensations. So you guys will see as we get into more of the symptoms of schizophrenia that having a delusion or focusing on a beloved individual who has recently passed, or angels, that those are really very positive things, and that most of the things that people are impacted by who have these tried and true psychotic disorders, they're typically experiencing more negative types of experiences. So a few particulars about schizophrenia before moving on to the diagnostic criteria are that schizophrenia is not split personalities. This is actually a different diagnosis that's called dissociative identity disorder. We skipped over this particular disorder just because of the scope of the class. It's much more rarely diagnosed. There's a lot going on with that particular disorder in terms of the validity of the label. Ultimately, some of the reasons for the confusion boil down to confusion in terms of what schizophrenia means. Schizophrenia literally means split minds. And so for some, that, could lead to them jumping to the conclusion that that means split personalities. In reality, schizophrenia was named that way to kind of connote that folks with schizophrenia have kind of split from reality a little bit, but not that their personalities have split. Other reasons for the confusion have to do with media representation. Frequently, if you watch a movie with multiple personalities, the person's referred to as being schizophrenic. This has gotten somewhat better, but particularly if you go back a decade or so, like Me, Myself, and Irene, the Jim Carrey movie, that's an example I always give of a character who clearly has multiple personalities but is referred to as being schizophrenic. Other reasons for the confusion boil down to some of the differences between personalities versus voices in one's head. Those are distinct things. A personality is kind of entirely who a person is, and a person moving from one stage of personality to another versus having distinct voices existing within a person's head. So in a nutshell, they are not the same thing. Schizophrenia is not multiple personality disorder. That is a separate diagnosis entirely. The diagnosis of schizophrenia includes positive and negative symptoms. The distinction here can sometimes be a little bit tricky for students to kind of wrap their heads around. The way I always learned it is positive symptoms are the presence of abnormal behaviors. So I always remember that by emphasizing the P's. Positive symptoms, presence of abnormal behaviors. Basically what this means is these are symptoms that we're seeing in folks with schizophrenia that are abnormal, that we are not seeing in kind of healthy folks who don't have schizophrenia. So this would include things like hallucinations, delusions, disorganized speech, disorganized behavior. Again, these are things that are abnormal that we're seeing in folks with schizophrenia that we're not seeing in folks without schizophrenia. Negative symptoms are the absence of normal behaviors. So again, I learned this through the ends. Negative symptoms are the absence of normal behaviors. So this is basically all the other symptoms of schizophrenia, and I'll give you more examples later on in the class. But this would include things like not maintaining what we would consider to be normal hygiene standards, normal relationships, normal ways of emoting and expressing emotion. So we're seeing the absence of normal behaviors in folks with schizophrenia. And the diagnosis of schizophrenia is going to entail, in most cases, a combination of positive and negative symptoms. The positive and negative symptoms also have different bases in terms of which neurotransmitters are behind each type of symptom. And so knowing the difference also helps to explain why antipsychotic medication impacts some symptoms more so than others. And again, we'll get into the particulars of this later on in the lecture. Up first, though, are going to be our diagnostic criteria. So up first, schizophrenia is going to be diagnosed by the presence of 2 or more main symptoms within a 1-month period of time, less if successfully treated, meaning that if we observe that a person has like hallucinations, for instance, and we refer for treatment and we get a person on an antipsychotic and the hallucinations go away after 2 weeks, we can assume that if left to their own devices without medication, the symptoms would have persisted. And we don't want to just let a person experience abnormal symptoms if they're not wanting to experience those symptoms just for the case of diagnosis. So 1 month, less if successfully treated, or we can otherwise assume that the symptoms would have persisted. So these symptoms include delusions, hallucinations, disorganized speech, disorganized or catatonic behaviors, and then negative symptoms, which include things like a flat affect, those absence of normal behaviors, which we'll talk about later on. In addition, at least one of the symptoms must be delusions, hallucinations, or disorganized speech. So we've got kind of that critical symptom distinction here, very similar to what we talked about in reviewing the major depressive episodes, where we needed to see dysphoria or anhedonia as one of the main symptoms. In addition to that, we also need to observe a decrease with respect to the person's level of functioning. So ability to socialize, go to work or school, take care of themselves, those things have decreased. We need to see continuous signs of disturbance for at least 6 months. So this includes prodromal and residual phases of schizophrenia, which I'll talk more about here in a moment. I'll show you a nice chart that will lay out all the different phases of schizophrenia and will help distinguish between that 6-month time period and that 1-month time period that I mentioned earlier. And then finally, we've got our rule outs. We want to rule out other likely diagnoses, which include schizoaffective disorder, which is another psychotic disorder. It's basically a combination between schizophrenia and a mood disorder. We also want to rule out severe versions of the mood disorders, things like, major depressive disorder with psychotic features or bipolar disorder with psychotic features. We also want to rule out the effects of substance intoxication or withdrawal and medical conditions like Alzheimer's. Finally, we want to make sure that we are only diagnosing schizophrenia alongside autism if the psychotic symptoms are particularly prominent. This might seem like a strange one. I know that this was one of the things that kind of, made me do a double take, I guess, when I was an undergrad learning about schizophrenia. Is autism, like that seems like something that's completely unrelated, but there actually are a fair number of similarities between the two diagnoses, particularly as far as things like disorganized speech and disorganized behavior and the negative symptoms go, and we'll talk a little bit more about that later on as well. In a nutshell, though, for now, I suppose just know that there are a good number of similarities. And so we really only want to give the schizophrenia diagnosis to someone who has an existing autism spectrum disorder diagnosis. Really, if we're seeing those prominent hallmark psychotic symptoms, things like the delusions or hallucinations that there's really no explanation for from an autistic point of view. So there's several stages of schizophrenia. We've got the premorbid, prodromal, psychotic, and stable phases. The premorbid phase is really before the person is experiencing symptoms at all. That's really what premorbid is prior to morbidity, prior to any really type of impairment. So because schizophrenia typically onsets in the late teens to late 20s, depending on biological sex. This would really be kind of the childhood and maybe early adolescent years for most folks. There might be other things going on, but for the most part, we're not really seeing any of the symptoms of schizophrenia yet. So this is kind of the healthy premorbid phase prior to the onset of any type of psychotic symptomology. The prodromal phase is when we start to see the onset of some impairment. So we might start to see a decline with respect to the person's ability to function in school or at work, or with respect to self-care or in relationships. Just kind of start to see some indicators of functional impairment. And again, we call this the prodromal phase. Up next is the psychotic phase. This is when those positive symptoms are really prominent. So this is when we start to see delusions, hallucinations, disorganized speech, disorganized behavior. This is also the phase that specifically needs to last for 1 month, less if successfully treated. Finally, we have the stable phase, which is when we don't see the psychotic symptoms as prominently, and instead we really start to see more of the negative symptoms and lingering impact of functional impairment. So we may still see social deficits or occupational deficits or deficits relating to self-care in addition to those negative symptoms. Without medication, without treatment, people do tend to naturally age into the stable phase, but treatment also helps to catalyze a person into that stable phase, whether we're talking about medication or more of a psychotherapeutic type of approach. So that psychotic phase has to last 1 month. And again, that's when those positive symptoms are really prominent. So delusions, hallucinations, disorganized speech, disorganized behavior, that's that 1 month period of time. Again, less if successfully treated. And then that 6-month period of time, that's kind of that collective continuous disturbance that we're looking for. Starts at the beginning of the prodromal phase and ends at the end of the stable phase. So that has to be at least 6 months worth of time. In reality, though, schizophrenia is a very chronic condition, and people are likely going to blow past that 6-month period of time. Similarly, people may have multiple psychotic episodes or phases throughout, particularly if a person is on medication and maybe isn't great about taking it consistently. So let's talk about each of those categories of symptoms, because unlike some of the other things we've talked about, most folks aren't quite as familiar with psychosis or schizophrenia. And so I like to take some time to boil down each and every symptom with plenty of examples. So up first, we have delusions. I've included an asterisk here because remember that this is a critical symptom, one of the ones that a person not necessarily has to have, but you'll recall that a person must have either delusions, hallucinations, or disorganized speech. So it's one of those kind of critical ones. Again, very similar to how anhedonia and dysphoria were the critical symptoms for the major depressive episode. And then the positive sign, the plus sign, indicates that this is a positive symptom as well. So I'll kind of have that shorthand for you at the top of each of these slides. So to recap, a delusion is a false belief. It's very rigid, which is something that we've covered thus far in this class. We've talked about how when someone gets to that delusional space with something like body dysmorphia or anorexia, that delusion's very rigid. It's difficult to argue with a person who's delusional or kind of rationally walk them through maybe the pitfalls of their belief. It's a very kind of steadfast false belief. The most common type of delusion is a persecutory delusion. In a nutshell, persecutory delusion is a belief that others are out to harm, kill, hurt an individual. And this is going to be the most common. So believing that someone else is hunting you down, trying to kill you, trying to hurt you, those are all going to be persecutory style delusions. We also have delusions of influence. These are beliefs that one's thoughts or behaviors are being controlled or monitored by others. So I believe that the government is watching me, or I believe that I've been implanted with some mind control device or monitoring device. Those would all be delusions of influence. We also have delusions of significance or self-significance, which is where an individual believes that they themselves, objects, or events are more significant than they really are. So John, the manic mechanic, the example I gave you for bipolar, while he had a bipolar diagnosis, he was definitely delusional, and more specifically, his delusions were of significance and self-significance. He believed that the newspaper clippings were more significant than they are. He also had a really grandiose sense of self, and that he believed he was really more important, more special, more significant than he really was as well. A really famous case study that has to do with delusions of self-significance really is the Three Christs of Ypsilanti. This was an inpatient asylum type unit in Michigan in the 1960s, and there were 3 patients on staff, all of whom had the same delusion that they were Jesus Christ reincarnated. Or Jesus Christ kind of come back. And what the staff decided to do is to put all three of these guys together, to kind of hash it out and figure out which one was in fact Jesus come back and which two weren't. This is not a recommended treatment approach. It's just kind of one of those old school, wild, mid-century psychology stories, pre-IRB, pre some of the ethical regulations that we have now. Interestingly enough, like it kind of worked, or I guess it worked probably as well as you could have expected it to, in that they did agree that the one guy was Jesus and the other two weren't, which helped the prognosis for the two guys and definitely worsened the prognosis for the other one. But it's a really interesting case study. If you're interested in kind of old school psych experiments or cases, this is definitely one to check out. And it's written by one of the psychiatrists who were on staff at the time. Finally, we also have somatic delusions, which are going to be delusions or beliefs relating to one's body. So one might believe that one's body is rotting away, for instance. It's important to take note that these are beliefs only, not sensations. If a person were to feel that one's body was rotting away, that would actually be more of a tactile or feelings-based hallucination instead. Which brings us to hallucinations. So hallucinations are also going to be a positive critical symptom. Only here we're dealing with false perceptions versus false beliefs. As I mentioned before, they can affect any of the five senses. Auditory hallucinations are actually the most common. That surprises a lot of people. I feel like when a lot of folks think about schizophrenia, they think about seeing something in the corner. Or seeing something that's not there. In reality, the vast majority of folks who experience hallucinations associated with psychosis are hearing things. About 3/4 of folks are hearing things. These are most often negative, berating types of things that people are hearing. It may be a singular voice or multiple voices, and the voices may speak about the person, like a peanut gallery kind of style, or to the person directly. Visual hallucinations are actually indicators of more severe cases of schizophrenia, and they really impact about 14% of cases, so much less common. In terms of what people see, it's most commonly religious figures or deceased individuals, but there's definitely a negative valence here. So we're not really dealing with angels or beloved loved ones, but demons, satanic types of imagery, scary imagery, maybe deceased individuals that you might not have had a great relationship with, things like that. Tactile hallucinations or feeling things are about as common as the visual hallucinations. They include the formications that I talked about earlier in the context of the substance use disorders and alcohol withdrawal. And it's basically just going to be feeling something on the body. And again, it's typically something negative. It's not like feeling, Sherpa on you all day. It's typically feeling like creepy crawlies or rot or things like that. And then finally, the olfactory and the gustatory hallucinations are the least common, impacting the senses of smell and taste respectively. And again, these tend to be negative, like smelling or tasting rot or something foul. Disorganized speech or thinking is going to be our final critical positive symptom. Disorganized speech is really the symptom that we're looking for, the tangible symptom. But the reason we're looking at speech isn't because schizophrenia is a speech pathology, but rather, if you think back to the definition of psychosis in general, one of the things that indicates psychosis, that lack of touch with reality, is distorted thought processes. But there's no real way to observe what a person's thinking, and so we infer thought patterns by looking at how a person is speaking and how thought is translated into speech. So these are some examples of disorganized speech that we may observe. We may see something called a loose association, which is when a person is speaking fairly tangentially, and you can kind of connect one thought or sentence to the next, but you really kind of have to work at it. There's not a lot of sense in how a person is connecting their thoughts. So an example might be something like, I once worked at an army base, soldiers are important, the Middle East, I like to travel, I love Arizona. You can kind of get from A to B to C and so on, but that collectively those sentences are nonsensical and don't really impart any meaning. We may also observe long pauses in speech. These are important because they may indicate something called thought blocking, which is when an individual is specifically trying to block out a hallucination, or more commonly, or a hallucination or delusion. And so because they're kind of focused on this internal experience, they may pause for a long time in their speech to actively block out the other pieces that they're thinking about. And so what we see isn't really that long process, but instead that pause in speech, long pause in speech. Finally, we might see a clang association, which is where a person speaks in a more kind of literative type of way. So rather than, again, kind of speaking in a straightforward, rational, sensible way, a person may string together thoughts on the basis of alliteration or some kind of rhyming scheme instead. So like, I have bills, summer hills, bummer, drum solo, polo. Again, you can kind of get how they got from A to B, B to C, so on and so forth, but there's really no sense in this string of phrases other than the person connecting things that are rhyming. And so these aren't exhaustive. There are other examples of disorganized thinking. These are just some of the prominent ones that I like to highlight for students. And so now we're on to disorganized behavior. So this is also a positive symptom, but it's not a critical one. So it's one of the rarer ones. We don't see it in all cases. It's not as common as the disorganized speech, the delusions, and the hallucinations, but it is positive in that it is an abnormal behavior that is present in folks with schizophrenia that we're not seeing in folks who don't have schizophrenia. The symptom in and of itself is simply disorganized behavior, but catatonia is going to be the most common manifestation that we see. Catatonia, broadly speaking, is when a person is awake but unresponsive to external stimulation. So that's going to be our definition. And it's a little bit more of a broader general definition than most people think of. When most people think of catatonia, they think of like comatose, like a person being like in a coma, laying in a bed, not moving, eyes potentially closed, not responsive, in the same way that someone in a coma is still and not responsive. And that can definitely be one way that catatonia looks. Catatonia, however, can also take the form of someone being awake and alert, but otherwise unresponsive to what's going on. So you can have a person who is mobile or immobile. So a person can be still laying down, or a person can be walking around. A person could be pacing back and forth within a room. So they're awake, they're moving, but when you try to interrupt them or get them to stop, they'll kind of swerve around you and keep going. They're unresponsive to the stimulation that you're providing that would typically indicate to a person like, hey, what's up? Stop, I'm here. Can you talk to me for a minute? They're not responding to that input. A person may make eye contact or none. Their eyes may be open, they may be closed. Ultimately, a person does need to be awake. They may be speaking, or they may be mute. They also may be rigid or waxy. Rigid means that a person is firm, they're not moving, so their muscles are very tense. Waxy would be kind of like what this image is depicting, where the woman kind of has a Gumby, flexible type pose with her hand above her head, where you could try to move a person and they would allow you to move them into a new position. There are several really great actor portrayal examples on this clip, so I would recommend pausing to watch this one. This kind of walks you through several different examples and just kind of gives you that visual for what catatonia looks like. In a nutshell, though, remember that the person's awake but unresponsive to external stimulation, and again, could be mobile, immobile. So it definitely includes this comatose type version that most people imagine, but it also includes a whole host of other behaviors or forms as well. And then finally, we have negative symptoms. So again, negative symptoms are going to be the absence of normal behaviors. So these are things that we would really kind of expect someone with, a healthy individual to do that we're not really seeing from folks with schizophrenia. So at first we might see diminished or inappropriate emotional expression. So typically we would expect from a normal, healthy individual that, if something sad is happening, they are, slowed down, and there might be sadness there. If something exciting is happening, a person's voice might go up and they might laugh or appear excited. From someone with schizophrenia, though, we might see laughter when describing something serious, or we might just get a really flat, monotone type of voice and emotion that just doesn't really change despite what the person is talking about. We might also see anhedonia, our old depressive symptom. So, it's normal to enjoy things that you like and to go do them and feel motivation for those things. It's abnormal, as in the case of depression, to not and do or enjoy the things that you typically enjoy doing. Avolition and apathy are basically terms that mean a lack of motivation. So it's normal to feel motivation to do things over the course of the day. It's abnormal to not feel that. Alogia is a decrease with respect to the quantity or quality of speech. So this is different than the disorganized speech we talked about earlier. Alogia would be someone who is mute or is not speaking a lot, or maybe they are speaking, but they're kind of slurring their speech and mumbling, and it's really difficult to kind of make sense of what it is they're saying. So in that case, the quality of their speech is decreased. We may see psychomotor retardation, which is kind of this lethargy, person not moving around as much. Again, tried and true depressive symptom that you guys should be familiar with. We normally expect people to move around, so it's abnormal to see them not doing that. We may see cognitive impairment in a variety of different ways. One such way might be a person who can't really think in more abstract types of ways. So when asked, what does the phrase "people who live in glass houses should not throw stones" mean, a person might respond, well, build a house out of bricks. Completely kind of missing the more abstract meaning to that common phrase. We might also see social impairment, poor self-care, poor hygiene. And again, the reason these are all negative symptoms is because these are things, the opposite really of these symptoms are all normal things that we would expect to see from people. And we're really noting the absence of those normal behaviors here. It's important to note that negative symptoms are oftentimes not addressed or worsened by antipsychotic medication. And that is because of the neurotransmitter that is responsible for negative symptoms versus the neurotransmitter that is responsible for positive symptoms. Positive symptoms are more driven by dopamine versus the negative symptoms are more driven by serotonin. And antipsychotics address dopamine and not serotonin, which is one of the reasons that negative symptoms persist even after a person has begun medication for schizophrenia. This is an excellent video. Definitely pause and watch this one. This is 4 different cases of schizophrenia. So it shows the variety, because there are really so many ways a person can fulfill these criteria. And so this is a great video that goes over the variety of schizophrenia. It is a little bit old, but the symptoms are still excellent. So in viewing it, just ignore some of the text descriptors as some of that information is outdated. This video was also designed more for med students, and so there are some tidbits in there that simply aren't relevant to this class. So ignore the text and just kind of watch the videos for what they are. I would recommend, as an exercise, sitting down and writing out the different symptoms that you see and taking the time to explain why that symptom is present, making sure that you really understand the symptoms that you're seeing, because you'll really get a good glimpse of everything. A couple of things that I will point out that I always like to highlight for students when I'm viewing this in person are that the TV tooth guy, he's a really good example of alogia. in that he's telling a fairly straightforward story about TV tooth, but the quality of his speech is so poor that it makes it difficult to pick out exactly what it is he's saying. So he's a really good example of the negative symptom alogia, whereas the female case, the only female case out of the 4, she's a good example of just disorganized speech. It's really easy to understand what it is she's saying, but she's jumping around so much. Her speech is clearly disorganized. And so sometimes I like to point out that the difference in some ways between disorganized speech and alogia is that alogia, it would be really difficult to type up a transcript for that person, but overall the story is relatively straightforward. Versus for someone with disorganized speech, it would be really easy to type up a transcript, but the content of the transcript just doesn't really make any sense. It's not a straightforward story. And then the other piece I like to point out about these 4 cases are that the 4th case, he has a little bit of catatonia. He has a little bit of disorganized behavior. He's twirling his hair throughout the interview, and that's a good example of just the behavior that's disorganized, that doesn't make sense. It's also closely catatonic in that he's awake, he's alert, he's talking to you, but he's kind of engaged in almost this tick-like behavior, and isn't really responsive to the fact that that's abnormal. Like if you were to walk around campus just twirling your hair like that, you'd probably get some strange looks. Someone might even comment, all kind of social indicators that like, hey, this is odd, you know, I guess continue if you want to, but this is odd. It's not really meshing with social norms. Maybe you should cut it out. And he's clearly not aware of or responding to those cues. So there's plenty more, but those are the 2 pieces that students typically need a little bit of extra help and explanation in recognizing. So watch these, take note of what you see, but then those are kind of the 2 added things that I always try to emphasize for students because they can be a little bit tough to pick out on your own or explain on your own. And then the final thing I want to talk about relating to schizophrenia before moving on to causes and treatment is autism. So as I mentioned earlier, the final piece of criteria for schizophrenia is making sure that we're not misdiagnosing autism. And there are some reasons, you know, as I mentioned before, there's definitely some symptom overlap here. Both have symptoms relating to thought. With schizophrenia, we've got the delusions. With autism spectrum disorder, we have more poor flexibility as far as thoughts go. So a person will get really focused on routine, for instance, and you know, we do this and then this and then this and then this, and they're just not super flexible in terms of those types of thoughts. So we've got thought symptoms in both areas, but those areas are distinct and different. And a delusion is distinct from poor flexibility when it comes to thought. So delusions are one of those things to maybe look for to distinguish that, yes, in fact, schizophrenia is also present here in addition to autism. Similarly, full-blown hallucinations are also a distinctive feature. Hallucinations relate to the symptom area of perception, sensory perception, versus folks with autism spectrum disorder. They have more perceptual differences, but not full-blown hallucinations. So someone with autism might perceive sound to be much louder, colors to be more vibrant. They might have preferences as far as textures go, textures with food, textures of clothing, but this isn't feeling, hearing, seeing, smelling, tasting something that's not there. It's just perceiving those things differently. So again, full-blown hallucinations would be kind of a distinctive feature indicating that schizophrenia is also present. Behaviorally, we can definitely see disorganized behaviors across both areas. So catatonia is unique to schizophrenia, but it can be common in cases of autism to see tick-like behaviors that, you know, kind of resemble like the hair twirling from that one video that you guys just watched. Other things that you'll see from autism that are unique from schizophrenia are the lack of flexibility when it comes to behaviors. And some of that goes to that back to that routine stuff I mentioned earlier. Folks with autism really prefer routines. And so, there's a way of doing things and there's a way of not doing things. But that is very distinct from schizophrenia. Again, an area where you might see more overlap might be with respect to those tic or repetitive behaviors. As far as other symptom areas, with schizophrenia, you've got the negative emotions, which can include a lack of emotional expression or motivation. With autism, there might be difficulty in understanding or using communication. But I mean, there's definitely probably the most overlap in the area of the negative symptoms. As you can see, flat communication from the autistic community. You can see communicative differences. So that's definitely an area where you're going to see more overlap. So again, when I kind of teach these things, I typically direct folks to more of the presence of delusions, hallucinations, as kind of, when you're seeing those things, those are really reasons to move ahead with the secondary schizophrenia diagnosis. But the disorganized speech, mutism, echolalia, which is repeating something that someone has just said, negative symptoms, tic-like behaviors, these are all things that we could really see from both camps. And so if those are your reasons alone to diagnose schizophrenia in a case that already has a standing autism diagnosis, I wouldn't diagnose schizophrenia. I would really, again, only move ahead with the secondary diagnosis if we're seeing those prominent delusions or hallucinations. As far as schizophrenia and drugs go, about half of people with schizophrenia have some type of substance use disorder. One of the reasons for this is self-medication, because as I mentioned before, antipsychotics address positive symptoms, but not negative. And so people oftentimes will self-medicate to deal with the negative symptoms. And this is supported by the fact that comorbid patients often do have fewer negative symptoms. This is correlational data, not experimental. So folks with schizophrenia aren't being given drugs to cope with negative symptoms, but correlational data indicate that patients with schizophrenia who also drink or use other substances do have fewer negative symptoms. And so it is kind of working to a degree. So that does support the self-medication hypothesis. Use may also be related to what's called downward drift. Downward drift is a hypothesis that explains the association between a schizophrenia diagnosis and a lower SES. Those two things are connected. One hypothesis is, okay, well, is there something about being at a lower SES that makes you more vulnerable to schizophrenia? But the downward drift hypothesis says instead that no, it might not be as much about a low SES causing schizophrenia, but instead that once people have schizophrenia, regardless of what SES they're at, that it's difficult to hold a job, it's difficult to maintain relationships, it's difficult to take care of yourself. And so people may lose jobs, lose housing, and gradually drift downwards on the SES ladder until they arrive at that lower SES. A final piece that I want to point out about schizophrenia and substance use has to do with violence. You guys may recall from my lecture on language that if mental health is not relevant to violence, it's not important to mention it because it just reemphasizes this myth that folks who have mental illnesses are violent when that's not the case. About 8 to 15% of folks with schizophrenia have committed crimes, while 16 to 34% of that group are victims of crimes. A lot of this has to do with the deinstitutionalization that happened in the 60s, where asylums were closed down broadly, but there was really no plan B, no replacement, which drove up the number of homeless individuals, specifically homeless individuals with schizophrenia and other severe diagnoses that would have landed them in an institution in the first place. And people at large typically fear things they don't understand, they aren't familiar with, which would include the homeless population. And so those are some reasons for kind of these myths. But in reality, if you really want to identify a group within the DSM who is more violent, it would be the substance use group. Folks with addictions, with substance use disorders, this is a group that's more likely to be violent. Not everyone in the group is violent, but if you want to identify a group with a greater propensity to violence, it would certainly be substance users over folks with schizophrenia. Finally, I kind of touched on this earlier, but just to reiterate, schizophrenia is not dissociative identity disorder. It's not multiple personalities. Multiple reasons for the confusion, which I touched on earlier. Some have to do with the literal meaning of the term schizophrenia, confusion between auditory hallucinations versus multiple personalities, media misrepresentation. Another reason is that both are kind of considered to be the epitome of severe psychiatry, along with like the bipolar disorders, again, these things that aren't understood, and so sometimes can be kind of lumped together inappropriately. In reality, DID is kind of this funky thing that has a strange past, and it really started to become more widely known within the general population in the 70s when a book called Sybil came out. Sybil was written by Flora Retta Schreiber, and it entailed the true story of a woman named Shirley Mason, who was described as Sybil in the book, who had 16 different personalities. Interestingly enough, after Sybil became popular and other cases of DID became popular in the media, we started to see more and more cases being diagnosed worldwide. So going from relative obscurity, under 100 cases in the 70s to thousands of cases in the 80s and tens of thousands of cases in the new millennium. What's interesting, though, is that Shirley's case was ultimately determined to be a fake. Not an intentional malignant kind of fake, but that Shirley was a woman with a really intense trauma history, someone who was heavily medicated as she was going through therapy, someone who really desired attention and kind of saw that her therapist was interested, when she would talk about different parts of her life, or that her therapist became more interested when she provided information about alternate personalities, and that her therapist also used several coercive therapy techniques, such as, well, what would your childhood version of you think about that? And so when she answered questions like that and kind of provided more information about the different parts of herself, that she got more attention and there were more questions along those lines, which just kind of led to her eventually endorsing these 16 different personalities. Lots of subsequent cases are really similar. There's a really high number of alters, so like 16, 17, 18, 19, 20, 21 different personalities versus seeing a lower number. There's typically a trauma history, and typically the alters only appear after the person's begun therapy. About 80 to some studies suggest 100% of alters appearing after the beginning of therapy. This suggests more of a sociocultural model for this particular diagnosis, where in the presence of therapy combined with media portrayals of what multiple personality disorder is, produces this DID presentation. Several studies have kind of explored this theory and this diagnosis more, recently. One such study that came out in the early 2000s gave healthy participants cues that could produce DID, and those individuals produce symptoms. So, for example, if therapists sat down with these participants and asked questions, kind of like the ones I gave earlier, what would your younger self think about this? Or do you ever feel that you have like an evil side or something like that? That when you give healthy folks these cues, they can produce DID-like symptoms, indicating that it might be an approach that can elicit these symptoms from people. And another study suggests that the more therapists believes in DID, the more likely they will give patients the diagnosis. So, are these disorders, is this disorder even real? Um, some of this research is heavily suggesting that it's not an authentic diagnosis in quite the same way as like depression or the bipolar disorders are. You don't just suggest the idea of sadness and then it becomes real for people, or suggest the idea of suicide or trauma and then it becomes real for people. Other support comes from history. There aren't really a ton of historical cases of DID. So, I mean, the DSM-1 came out in the 1950s, but I mean, you can go back and find examples of personality disorders and bipolar disorders, mood disorders, and psychosis, across history, even though we may have had a different name for them at the time. But there's not really an authentic historical case example of multiple personalities, suggesting that it's probably this combination of media portrayal and accidental coercion that has kind of elicited the large number of cases that we have today. That being said, though, there are a few modern cases that have demonstrated impressive differences among personalities. One study that I'd read was listing off differences in handedness. So one personality was left-handed, one was right. And vision differences. So like if you were measuring a person's vision, like one personality had like 20/20 vision and one personality had a very different vision. And so indicating that the brain was physically functioning differently across these different personalities. These are case studies, so we're talking like single digit case studies. And these individuals also have like two maybe alternate ways in which their brains function. So very different than the Shirley Mason big kind of blockbuster idea of what multiple personality disorder is, where a person's got, 21 personalities and some of them are committing crimes and yada, yada, yada. So funky diagnosis, definitely some cultural pieces to it. The big takeaway is that it is distinct and different from schizophrenia. A few other considerations. Schizophrenia is very rare, impacting about 1% of adults. About half are comorbid for things like depression, anxiety, and substance use. Females develop schizophrenia in milder forms and later than males, more typically in the mid to late 20s compared to late teens to early 20s in males. And females also have milder symptoms, potentially due to the fact that they develop symptoms later, also potentially due to socialization. Those are some of the explanations for that trend. There is a racial bias favoring the diagnosis of schizophrenia among African Americans. There doesn't appear to be as much of a legitimate racial difference, more that when presented with two identical cases, one white, one black, clinicians are more likely to label the black case schizophrenia and the white case a bipolar disorder. So that's just an important bias that exists out there that is important to be cognizant of, specifically if you end up working in the area of schizophrenia or mood disorder, to really pay attention to symptoms and not let the race of a person sway your diagnostic decision. Suicide risk for this group is highest at the onset of symptoms and then immediately before and after hospitalization. Some of the reasons that it's high after hospitalization is that this is a time when a person is shifting from an area where there's a ton of supervision, a ton of support, back to the real world where there's not. And so that can bring back suicide risk, even though it might have decreased during hospitalization. So that's important to just be aware of, just as a layperson or as a professional working in this area, that after the hospital isn't necessarily a time to be like, oh, great, you're cured now, but that's a time to really kind of watch out for this group too. Self-harm is high for this group, and environments with high expressed emotion can increase the chance of relapse. High expressed emotion is loud, negative environments. So environments where, mom and dad are yelling at each other all the time. If we're releasing a young adult back into that environment, that's going to increase the likelihood for relapse. Causes include high levels of dopamine. That's the dopamine hypothesis. And we've linked dopamine more so with the presence of positive symptoms than negative symptoms. There's a strong genetic piece to this. There's a 60 to 85% monozygotic concordance rate, meaning that if one identical twin has schizophrenia, there's a 60 to 80% chance that the second one will as well. So that's highly genetic. That's up there with the bipolar disorders. And then prenatal viral infections can also increase the likelihood of a diagnosis for the baby, not the mother. So if mom had a viral infection with baby, that increases the likelihood of baby later potentially being diagnosed with a psychotic disorder. Minimally, but it is a risk. I do want to review schizophrenia in old age because while it is more common to see the onset of schizophrenia in younger folks, it is something that you'll sometimes see emerge for the first time as a person gets older. Many of the cases of psychosis in older adulthood are typical traditional cases. So you'll see that, I mean, on the slide, we're reviewing late onset and very late onset schizophrenia, and that collectively these two things account for only 20% of psychotic cases in older adults, meaning that 80% of psychotic cases in those over 65 are the traditional kind that begin in the 20s and persist throughout life. But for about 20% of people, they don't develop psychosis until after 40 in the case of late onset, or after 65 in the case of very late onset. Late onset is pretty similar to typical schizophrenia. Paranoid and auditory hallucinations are common, but it is different in that these individuals are often higher functioning, which probably has to do with age. Typically, the older you are when you develop schizophrenic symptoms, the better off a person is, because they had 40 years of healthy pre-morbid functioning versus 18. It's also more common among women, suggesting that potentially estrogen's protective. And so it might have more to do with like women going through menopause and developing symptoms as their female hormones decrease. Very late onset would be after the age of 65. This is very different from other types of schizophrenia. It's less associated with a family history of schizophrenia and more so associated with a family history of medical illness, like Alzheimer's, or present medical illness like Alzheimer's. Misidentified caregivers and visual hallucinations are more common, and there are also fewer negative symptoms. And again, collectively, these make up about 20% of cases in older adulthood. The vast majority of psychotic cases among older adults are the typical kind that begin at a much younger age. As far as treatment goes, antipsychotic medication blocks dopamine receptors, improving positive symptoms, but having no effect on negative symptoms or cognitive deficits, and in some cases making those things worse. There are several different psychosocial treatments as well, things like psychoeducation, just talking to folks more about what schizophrenia is, teaching family and loved ones about schizophrenia, the detriment of expressed emotion, things like that. CBT and mindfulness-based approaches can be helpful in aiding individuals to live with hallucinations and delusions, especially early. I'm working one such case right now where we're not as much working on decreasing the presence of fairly benign hallucinations, but we're working more on how this person is responding to those hallucinations and the meaning the person is attaching to those hallucinations, so that they can just kind of let them be, not get so worked up, not get so bothered, and just kind of accept them as something that isn't really there, but that they're seeing. And finally, we might do some social skills training to help a person get a job, form relationships, things like that. So that's treatment. And the last thing that we're really going to talk about today is we're going to take a step back and take a look at medication for schizophrenia, but also kind of medication in general, because there really are a lot of misnomers out there about like the chemical imbalance theories of mental health and mental health disorders, and the efficacy and effectiveness of medication. And so we're just going to talk about that a little bit more using schizophrenia and antipsychotics as examples, just because schizophrenia is one of those things that, you know, antipsychotics are really viewed as the gold standard treatment. And so we're going to just kind of use this as an example to just kind of explore medication more. If you're interested in this subject, I highly recommend the book Anatomy of an Epidemic by Robert Whitaker. That's where I'm pulling a lot of these case examples and stats from. It's a fascinating book that explores the history of psychiatry and medication, and just whether or not this stuff is really a good idea, whether or not it really seems to work. So the basis really for this conversation is the fact that many Americans really believe that mental illnesses have physiological causes in the same way that medical diseases do. And this is what's referred to as the disease model, that this is physical in nature, it's got a physical cause, and in this case, we can point to chemical imbalance. 87% of Americans report that they know for a fact schizophrenia is caused by chemical imbalance, and 80% of Americans report knowing the same thing to be true of depression. So this is just kind of supporting this idea that this is a very popular idea in the United States. So given this belief, we rely on medication commonly as our first line of defense when treating mental illness. However, what we're really seeing is that psychotropic medications can really change how neurotransmitters function in the brain. And the brain often adapts in order to maintain equilibrium in the face of alterations in the environment. This is a process called oppositional tolerance, which is really just a fancy way of saying that we are introducing this medication that is messing with brain chemistries, messing with natural neurotransmitters, and the brain doesn't like that. The brain wants to maintain the status quo, how things were, and so the brain is actively going to be working to counter whatever it is the medication is trying to do. So let's explore this idea a little bit more using dopamine as an example, given that dopamine is what is relevant here in the case of schizophrenia with antipsychotics. So before medicating, graphic A kind of depicts what a neural exchange in the brain looks like. We've got two neurons who are communicating with each other across the synapse, our presynaptic and postsynaptic neuron. Presynaptic neuron releases dopamine that lands on the dopamine receptors of the postsynaptic neuron. The message is transmitted from one neuron to the other. The dopamine is taken back up by the presynaptic neuron, and so on and so forth. After antipsychotics, what happens is the antipsychotics are actively blocking the receptor cells on the postsynaptic neuron, so that there's no place for the dopamine to go. But what actually ends up happening is that the brain increases the number of dopamine receptors present to compensate for the drug blockade. So you can see just in this graphic that we've got 4 dopamine receptors pre-antipsychotics and 7 after antipsychotics. So now the person really does have a dopamine problem if they really were to quit their medication, because now they have twice as many receptors as they did in the first place. So the brain is actively fighting to maintain the status quo, to maintain homeostasis. And ultimately what this is again, it's something called oppositional tolerance, where the brain is countering what the medication is doing, and the medication ends up causing the problem it was intended to treat in the first place. So we prescribe medication because we thought this person had too much dopamine, but now we've caused the brain to fight back, and now if the person ever were to stop this medication, they really would have a dopamine problem, because now they have twice the number of receptors that they did before. But who cares if all this stuff is happening in the brain? Pills seem to work, right? This is one of the landmark kind of psychotropic medication studies that came out in the 1980s. This one focusing more on Xanax and panic disorder. As you guys can see from the graphic, over a 4-week period of time, Xanax successfully decreased the number of panic attacks that people were having compared to the placebo, and resulted in newspaper clippings saying things like, "This study provides a demonstration of the efficacy of Xanax compared to placebo in the short-term treatment of panic disorder." And Xanax works for 70 to 90% of those with panic disorder. In a panic, help is on the way. But then again, these are more the actual study results. So this is a good example of not necessarily outright lies, but more just misrepresentation or prematurely reporting drug data. So this is the same study, and you can see if you look at weeks 0 through 4, that's the same data I showed you on the last slide. But if you span out a little bit further, that you can see that over time, if we taper off of the drug, so if we leave folks on the placebo or on Xanax for a period of time, and then we taper the person off of the drug, that we've already seen those brain changes over just a few weeks. And that in the long run, folks who started with the Xanax and then quit now are experiencing way more panic attacks than the folks who were on the placebo and then came off the placebo. And we see similar results when examining depression, schizophrenia, ADHD, and bipolar disorders, that if we look at people on medications for long periods of time, or people who were on medications and then came off of medications, that in the long run, they frequently have more pathology than people who were on placebos or just weren't on medication in the first place. One of the reasons the medication can be so enticing is because it works really quickly, like we saw during this active treatment period. And the placebos or therapy can work a bit more slowly, but typically in the long run, we're not dealing with these damaging brain changes, this oppositional tolerance that's really causing a lot of damage in the long run. So here's a study that is looking more specifically at schizophrenia. This one's also a bit more recent. This data came out in 2007. This is looking at long-term recovery rates. So higher numbers are better than lower numbers in this scenario. And this is also looking further out. So we're not looking at, a few weeks to months into treatment, but we're looking 2 years out, 5 years out, 10 years out, 15 years out. And what you're seeing is that less than 10% of people on antipsychotics are fully recovered from schizophrenia 15 years out. And that's pretty consistent starting at the 2-year mark. But folks off antipsychotics, about 20% are recovered at 2 years, and that number goes up to about 45% over 15 years. So schizophrenia is just kind of a tough egg to crack. It's just very chronic with or without medication. So still, about half of people aren't recovered, but the recovery rates are certainly much higher for people who are not on antipsychotics, because we're not messing with their dopamine levels even more. Pre-medication era, we saw indicators that mental illness wasn't quite as damaging as it is today. So in 1921, Emil Kraepelin writes, 60% of 450 patients hospitalized for an initial bout of depression experienced a single episode, and only 13% had 3 or more episodes in their lives. So that is very different than how we know depression functions now. Nowadays, if you've got 1 episode, it's very likely you'll have subsequent episodes. So the notion that most people would only have 1, and really only a subset would have 3 or more in their lives, is very different than how depression functions now. Similarly, in the 60s, a German physician writes that exposure to antidepressants appeared to be shortening the intervals between depressive episodes. So people seem to recover from the one, but then relatively quickly move into another one. In the 70s, we see another quote, the antidepressants were inducing a change to a more chronic course. Similarly, in 2000, poor outcome in mania was considered to be a relatively rare occurrence, whereas now mania is one of the more debilitating, I wouldn't even say simply mood states, but mania is one of the more debilitating really conditions within the DSM. So these are quotes, and I'm kind of juxtaposing quotes with research to kind of give you a variety of support. But these are quotes that are basically suggesting that many of the things that we consider to be really chronic, really severe today were not always as chronic and severe. That it was common for people to have a single episode of something. It was common for mania to be, something very livable, something not super impairing. Post-medication era, we start to see more and more support for the idea that things like mood disorders are very recurrent, very chronic in nature, highly distressing, highly dysfunctional. Used to believe that many patients would eventually recover from major depressive episodes. More extensive studies are disproving that assumption. It's now known that depression is highly recurrent. A study by Martin and colleagues in the early 2000s of almost 90,000 participants with depression determined that about 7.7% per year developed bipolar when treated with an antidepressant. This is 3 times the base rate. So folks who were not treated with depression didn't develop bipolar as frequently. So people with depression who received an antidepressant medication more commonly eventually developed mania or hypomania versus folks who had depression, weren't treated with an antidepressant, less commonly developed those manic or hypomanic episodes later on. So again, all kind of support that these things that we think of as being really impactful, chronic, didn't always used to be that way. And that goes alongside much of our disability data, that if we track back the number of adults who are on disability with the US Social Security Office, that those numbers have skyrocketed since the 70s and 80s when we started to see medication being used more and more. Again, suggesting that, while immediately these things may seem to be really good, in the long run, they may be causing much more pathology and impairment. One of my favorite studies exploring medication, and in this case, exercise for the treatment of depression is this series of research that has steadily been coming out since the 2000s from Duke. These are the Zoloft and exercise trials. What this study did was it divided participants with major depression into 3 groups. One group was treated with Zoloft, one was treated with exercise, and one was treated with Zoloft plus exercise. They were treated over 16 weeks and then monitored after that to see what they looked like at 6 months and what they looked like at 10 months. So they were no longer treated after the 16 weeks, but we just kind of followed them to see what happened, or researchers followed them to see what happened. For folks who were exclusively receiving the medication, about 70% were in remission at the end of that active 16-week period of time. And those numbers were pretty similar across the exercise and the combination groups. About 66% in the combination group being in remission and 60% in the exercise group being in remission. But what's really interesting are the 6 and 10-month follow-up data. So at 6 months, 40% of people in the Zoloft group had relapsed, compared to 30% in the combination group and 8% in the exercise alone group. And then data are really similar at the 10-month follow-up. 50% were depressed, so had relapsed in the medication group, 55% in the combo group, and 30% in the exercise group. So what's really interesting there is that you might think that the combination group would do the best, but it actually seems like the medication impaired the ability of exercise to work. Exercise alone worked the best in the long run. And if you added medication in there as well, those people did worse than they would have done with just the exercise in the long run. So these are all kind of similar data suggesting this idea that medication is really exciting initially, but in the long run, it may not really be the best move. As it's changing brain chemistry and is doing so to such a degree that it's making it very difficult for you to ever get off of the medication. People also build up tolerances to the medication and so need more or need to switch to new medication. Whole bunch of stuff that can happen. So conclusions. Largely, we really don't know the biological origin of many mental disorders. The idea of chemical imbalances is actually an ad hoc hypothesis. It's not this clean thing that many people think that it is. In fact, this is a fun story, the very first antidepressant was actually a tuberculosis drug. This tuberculosis drug was obviously designed for folks with TB and given to folks with TB. But what researchers observed is that the patients with TB who were getting this drug seemed really animated and happy, and they were bouncing around the hospital ward. And so someone was like, hey, these guys seem really happy and energetic. Why don't we give this medication to these folks over here who are really sad and depressed and lethargic? And they did. And those folks, similarly had that behavioral and emotional change. And it was really kind of only after kind of randomly experimenting with drugs and giving them to mental populations to kind of see what worked and what didn't, that they came up with hypotheses relating to chemical imbalances. Like, okay, well, this drug, it has an effect on dopamine, so maybe it's dopamine that's kind of causing depression. That's what's called an ad hoc hypothesis. When you come up with a hypothesis after you've done the study, which if you've taken research methods, you know that is a no, we don't do that. And since then, it's just been a lot of like marketing and big pharma that has really kind of perpetuated this chemical imbalance. I would go so far as to say like myth. The original kind of use of these drugs was very ad hoc, as I said. And studies honestly support the idea that like, yeah, there are people with depression who have low serotonin levels, but there are also people with depression who have higher serotonin levels, and there are healthy people with low serotonin levels, and there are healthy people with high serotonin levels. It just isn't nearly as clean cut and straightforward as people think it is. It's not as a perfect disease model as there exists for other medical conditions. And in many cases, we have observed in the long run that these psychotropic drugs do induce the very abnormalities that were hypothesized to cause the mental disorders in the first place, which, as you guys know, is called oppositional tolerance. So we give a person an antipsychotic to block dopamine receptors, the person grows more dopamine receptors and now really does have a dopamine problem. Over the long term, many of these drugs increase the chronicity of disorders that they're supposed to treat. And since the publication of the DSM-3, there's been a significant increase in mental health disability, and much of this may have to do with the increased reliance on medication. So I'm not out and out saying that medication is a bad thing. And in some cases, I've referred my clients to a psychiatrist for medication. But I am saying that it's not this magic bullet that many people think it is. It does work acutely. It helps people feel better fast. And so I'll typically refer people to psychiatry when we've tried psychotherapy and it just isn't really clicking. And I'll refer people, and I'll typically give them a version of the spiel that, you know, these medications seem to work the best when they're used for a short period of time. And so that's what we're going to do. We're going to use this for a short period of time to give you a boost, and that we're going to use therapy while you're on the medication. And the aim going in is that this isn't permanent. We're going to use this medication for a fixed amount of time, and then we're going to try to come off of it. And we're going to do that during therapy as well, so that you have support for when symptoms start to come back as a consequence of coming off of the medication. And so if used, I always recommend that these medications be used for a shorter period of time, and that they not be used for long periods of time, and that they not really be glamorized, I guess, as these kind of magical solutions for our mental health crisis, because that just isn't really how they came about, and that's just not really what the long-term research is saying. So again, I kind of present this in the context of schizophrenia because of the reliance on antipsychotics, but much of this, as far as neurotransmitters and chemicals and oppositional tolerance and increased chronicity and mental health disability, a lot of this stuff really does apply to many of the other areas that we discussed in this class. And so that's one of the reasons that I like work more in the psychology side of things, and enjoy using therapy as an approach versus more of a neuroscientific type of approach. So that is that. And again, if you're interested in this, Anatomy of an Epidemic is a great read by Robert Whitaker. All right, that's all that I got for you guys.